is a mental disorder? Well, first we have to ask ourselves, the question is, what is normal? And that isn't a very easy question to answer. That's a very controversial thing. What is normal? Because normal has a lot to do with the culture in which you live, doesn't it? Within the Muslim culture, what we consider domestic violence in this country is probably not normal. It is normal in the Muslim culture, it's not normal here, is what I'm trying to say. As an example, in the Quran, it particularly says that if your wife gets out of order, you can beat her. We've had problems with that in counseling when we've had Muslims come in for domestic violence. They don't think they've done anything wrong. Because in their culture, that would be accepted. In our culture, that's not accepted. It would not be normal in our culture. It would be normal in their culture. How about suicide in Japan? Do we consider suicide normal in our culture? But suicide is looked up to in Japan in certain circumstances. I'll give you a situation. There was a Japanese lady here in America. And her husband was divorcing her. So she took her 2 kids and went out into the ocean to drown herself. Unfortunately, she only succeeded in drowning the 2 kids. And she survived. What was the defense? This is normal in the Japanese culture. When you've been shamed, the way you admit your shame. How many people during this last economic crash in Japan committed suicide to take responsibility for the failure of their company? Well, is that normal or is that not normal? How about, there's a tribe called the Wodabi tribe. In the Wodabi tribe, men wear makeup and bright clothing to attract their mates. If one of them came here to the United States and they were going around wearing makeup and bright clothing, what would we think? We might have a problem. Maybe there's something else. We might wonder if they have some sort of a problem or not, right? And so we have to realize that normal is culturally specific, isn't it? How about over history? Have there been differences in history based on the different situation? Think about the Spartans. They basically said to the boys, either win the battle or come home on your shield. They would take their children and they would put them outside on a hill after they were born for a period of time with no help whatsoever, so that only the strong would survive. What would we think about that here in America? It'd be reportable child abuse, right? Be all over the papers probably, right? How about the kamikazes? In our society, when we ask somebody to volunteer to smash their plane into an enemy ship, but that was looked at as some great sacrifice, as something great for that particular society. How about high achievement in our society? Everything is driven to get to the top of... driven people in our society are considered what? Successful. Something we look up to. Other societies would be aghast at this particular problem. See, you see, we have a lot... It depends on the group you're in that makes a difference of what we're talking about. It also depends on the circumstances, how a person reacts. See, in one case it might be normal, in another case it's not normal. Consider if right now somebody came into this room and started shooting people. do you think you might react a little bit different than you are right now? See, right now, what is normal? Sitting here, being quiet, taking notes, and listening. Would that be the same if somebody was in here starting to kill people? Would we think you were not normal if you were afraid? If you start screaming or if you jump through the window? Or you start throwing the desks over and start throwing chairs? See, it depends on how you look at a situation as to what is normal and what is not normal. So what is the criteria for what we call mental disorder? Let me sort of break something out for you, okay? Here we have normal, okay? In normal, people have some struggles, some problems, but they're generally functional, okay? Normal and functional sort of go together, okay? Then we have a term that we call codependency. These are people that are fairly dysfunctional, that they basically are struggling with things in their lives, and their struggles do affect their lives fairly significantly, okay? And then we have mental disorder. This is when they're affected so much that they're not functional, that there are problems there, and we have certain criteria for this. The first criteria is it deviant from what's expected in the society? See, is it deviant? In other words, does the society expect this, and this person is doing something significantly different than what's expected in this society? See, take the example of a panic attack. Do we expect that people, when nothing is happening and they're not in danger, all of a sudden are going to just start hyperventilating, feel tremendous fear, feel that they're going to choke, and are sure that they're going to die when nothing is happening? See, that's a deviant from the way we normally expect people to act, isn't it? Okay? Is it distressful? Does it cause a problem in the person's life? Now realize sometimes, just because it's that some of the things that we consider mental disorders are not distressful. Consider of a person in bipolar, as an example. We don't know exactly what that is. We'll get to that later. But another term for that is manic depressive. When they're in the manic stage, are they distressed? No, they're on top of the world. Everything is great. Everything is wonderful. Would they consider themselves in a mental disorder? No, they think it's just absolutely wonderful where they are. They don't want to change. That's why we have to have all these criteria. You see what I'm saying? Because in this case, distressful would not apply to that, but we're still going to call it a mental disorder. Dysfunctional. It interferes with daily functioning. Either your work or your family or something else. And finally, dangerous. Is it dangerous? Is someone going to get hurt by this? Is someone going to get killed? Or maimed or harmed by this particular thing that is going on? But here's the question. When is it deviant enough, distressful enough, dysfunctional enough, or dangerous enough to be a mental disorder? Well, the way that's determined is by a whole lot of people that get together and write something like DSM-4. Unfortunately, they are very much controlled by what our society says, and by politics, and by what people want. I'll give you an example. In the current writing of the current DSM-4 that we have, there was a major controversy over something called premenstrual syndrome. And they were trying to consider that to be a mental disorder. What do you think happened? All sorts of women's groups rose up and said, if you put that in DSM-4, then a large majority of women are going to have mental disorders every month. So therefore, guess what? It's not in DSM-4. It's in the area saying things we need to keep looking at. This is There's a whole lot of things over there. Another problem is there are a lot of things we run into in counseling that we're not going to find in DSM-4. Or if we are, we're not going to find it broken out very well. Certain things, because psychiatrists see a lot of them and so on, are very much there. There's even a whole controversy over whether we should even have personality disorders in DSM-4. Because a lot of the nomenclature of the personality disorders go all the way back to Freud and what they thought about back in his time. So this is a, should we say, artwork in the making. It is something that changes. It is something that is modified by the political situation as we go along. What are the prevalence now of these kind of mental disorders in our society? I'll give you just some of them to give you an idea. The suggestion is between 30 and 38% of adults and 17% of children need some sort of clinical treatment every year. And by the way, that clinical term generally means today having to do with mental disorders and DSM-4 and that kind of stuff. 13% have anxiety disorders. 6% have profound depression. 5% have personality disorders. 1% has schizophrenia. And what's interesting about that 1% goes across all societies. 1% has Alzheimer's, and 10% have addictions to drugs or alcohol. I'm not going to go into all of them, but I'm giving you a flavor of what number of clients, what percentage of, if you had 100 clients, what percent might have this. Historically, how have we tried to treat mental disorders? Well, the first thing we know about is a long, long time ago, they used to drill holes in people's heads to let the spirits out. And we haven't improved too much sometimes in some particular areas. You know, what we call a frontal lobotomy, isn't really too old in what we're talking about here. Hippocrates believed that there was an imbalance of the four humors or body spirits, and so they used to bleed people to try to help them. That was medically as well as psychologically. In the Middle Ages, it was seen primarily as acts of the devil, and so they treated them sort of like they were possessed. In the Renaissance, they started having asylums. But again, they were just concentrating and locking these people up if you wanted a little better treatment than they had before. In the 19th century, they got more humane treatment because they started realizing that some of these things were actually caused by physical things that they thought were mental. As an example, syphilis. So when people had syphilis and it went to their brain and they started acting crazy, they first thought that was a mental disorder. Now they realize that that's not a mental disorder. They realized also that hypnosis could actually create what they call a hysterical disorder, and the hypnosis could actually cure a hysterical disorder. That was one of the things, again, back about the time of Freud. In the 1950s, we had a major revolution of what are called psychotropic drugs. Up until that time, people with mental disorders were institutionalized. We took them out of the society, we locked them up, put them in straitjackets, did all sorts of interesting things, didn't give them very much help. But then in the 1950s, we started getting with Haldol and so on, we started getting more and more drugs that would help treat the person. And the direction right now that things are going within mental disorders is more and more doing CAT scans and looking at their brains and trying to manipulate the neurotransmitters in the brains and block the receptors and do all sorts of things. In other words, instead of fixing what comes into the computer, so we get something good out of the computer, we're now saying the problems are all on the computer, so we're going to modify what's going on inside the computer, so we put trash in and we get good things out. But that's generally the medical model that is pretty much taking over a lot of the treatment in this particular area. Now, why is that? we don't have good answers for a lot of these type of things. And there have been found certain drugs that do change and do help these situations significantly. We're going to find there are certain things that there's very little treatment that does anything for them, and once you put them on a drug, as an example, bipolar using lithium, just straight out. So there's a whole confusion of how much of this stuff is physical, going on in our brain and chemical imbalances, and how much of this is psychological. But the truth is this: the brain is a chemical computer. So every time you think, everything you do changes the chemicals in your brain. The question is, when is the brain so far out of kilter that you can't help a person through counseling? But in most areas, and we'll be talking about each area of treatment and what works and what doesn't work, in most of these areas, it's a combination of both. And there's a certain amount of drugs that do work and do help, and with the addition of counseling, that's usually the most effective combination. But we'll be talking about those, and it depends on the different areas. As an example, we have different ways of thinking about this. The first is what's called the biological or the medical model. That's what I've been talking about. That means we look at how the brain is functioning and we try and fix the brain function. You have the psychodynamic model. That's what was started by Freud. And we're talking, the idea here is that internal conflicts or past trauma is what's causing the problem. Behavioral says we use classical or operant conditioning to try to operate like we're basically a basic animal and change the way we relate. Cognitive says there are illogical premises in thinking that are going on, and that's what causes the problems. Humanistic said that self-awareness means self-actualization. The social culture model says it's outside stressors. So do you see what I'm saying? We have all these people out there saying that they think they understand these problems, and they have their own models as to how these problems are and how they work. And then we have the stress model that says that all that's happening is we're getting too stressed out, and that's what's causing basically our body to malfunction in one way or another. But all of these have one core chunk, okay? These are the things that are needed for a successful therapy. First, the person needs individual attention. Second, they need to be given a credible rationalization or rationale for why they have the problem. They have to experience mastery or success. They have to have their expectations raised that they're actually going to improve. And they have to have a trusting therapeutic alliance. Those are all the factors of what healthy basic counseling does to try and help the person. Now, in these areas I talked about, there are certain of them that are very effective in different areas. As an example, behavioral. Remember, that's the operant or classical conditioning. And that works very good for what are called phobic disorders or irrational fears. Drug therapy is about the only thing that helps with schizophrenia. Cognitive behavioral therapy works very good for panic disorders and sexual dysfunctions. Cognitive plus drugs works best for depression. I'm not going to go into the whole list, but you see what I'm saying. There are different things, so that's why you need to know these different areas to get an idea of what's normally considered most effective. Okay, so now how are we going to assess these problems? How are we going to figure out whether somebody has a mental disorder or does not have a mental disorder? We have a number of directions. One is what's called the clinical interview. You have a knowledge of what we're going to teach you in this class, and you sit down and you ask the person questions. And based on that, you say, I believe you have this particular mental disorder. Well, you don't have any mental disorders. But it's a purely judgment type thing based on how many people you see in your experiences. Secondly, we have tests. We have what are called projective tests, personality inventories, psychophysiological tests, neuropsychological tests, and intelligence tests. There's a whole bunch of them out there. The most usual ones are like the MMPI, Minnesota Multiphasic Personality Inventory. But intelligence tests, what's your IQ? Rorschach tests. Look at these ink blocks and tell me what you think, what they mean to you. You try and get an idea of where the person's coming from. We have clinical observation. That's the next one. And that basically says, I put you in a hospital and I watch you for a while and I try to figure out what's going on. And finally, we have diagnosis, and that's when we're talking about DSM-4 again. By the way, just so you know, internationally, there's another one called ICD-9. Okay, that's the international equivalent to DSM-4, and most of the stuff all relates one to another, but all the coding numbers are different. Okay, and you might have certain things that are considered mental disorders in ICD-9 that are not considered mental disorders in DSM-4. We're going to concentrate on DSM-4 because that's what's used primarily here in the United States. What are the things that come into DSM-4? Already given you an idea. Scientific, social, political, and personal aspects. Some things get into DSM-4 or not, basically just on a vote. As an example, we're going to find out that you will not find homosexuality in DSM-4. Why? Politically, the homosexual community, the gay community, has a fairly strong vote, and particularly when that came up for vote many years ago, I've been told anyway that 3 out of the 5 people on the committee that did the voting were homosexual. So they didn't think it was a disorder. So therefore it never got in. When they do that, by the way, they have many, many thousands of doctors that are all giving their input and their experiences and everything. But basically it becomes sort of a conglomeration of all of that together. Now within DSM-4, you have 5 different axes. Okay, you need to get this down because it's the basics of what we're going to be talking about in diagnosis later on. Okay? Axis 1 is what they call obvious or florid clinical symptoms that typically cause impairment. That's most of the stuff you already have heard of, like schizophrenia and bipolar and anxiety disorder. Those kind of things are all in Axis 1. Okay? Axis 2, and by the way, this is how these are different areas that you look at a person's life. Axis 2 are the long-standing disorders, which are primarily the personality disorders or mental retardation. See, do you understand why they have these? In the first case, you could have like somebody that is struggling with schizophrenia, but if you don't break it out, and if this person is also mentally retarded, that's going to have a major effect, isn't it? Of how you look at this, how you overall look at this particular person. Axis 3 is relevant medical condition. This person might also have a heart condition. This person might have Alzheimer's. The Alzheimer's would be over here in medical conditions. It would not be over in mental disorders in Axis 1. It would be in Axis 3. Axis 4 is psychosocial or environmental problems. Like they just lost their job. They've just been divorced. They're living in a dysfunctional family. That all goes in Axis 4. And Axis 5 is what's called the Global Assessment of Functioning, or the GAF. This is just a number, and the number says where the functional level of this person is. Obviously, the more problems you have, the less functional you're going to have. Your person's going to be, and the more healthy they are, the more functional. So you can just look at this number, and it gives you an idea of how functional they are. Now, how reliable is this thing called diagnosis. What does reliability mean? It means if we sit down, 10 psychologists, have them all look at the same, they're trained in this, and have them all look at the same person, do they come up with the same answer? So far, research says it's about 70% reliable. That means that 30% of the time they're going to come up with different answers. And 70% of the time they will come up with the same answer. It has pretty poor validity. What validity means is that, is this really measuring what it says it's going to measure? Okay? And since we're trying to measure mental things by symptoms like physical things, it has some problems. You see what I'm saying? Another real big issue in DSM-4 is like, is there only one types of schizophrenia they talk about, or are there a number of different types within each category? So it can get very confusing. It is not culturally sensitive. We take a person and we try and use DSM-4 on someone from the Fuji Islands. We're probably in bad trouble. Okay? The majority of clients that we use to do DSM-4, guess what they are? White. So therefore, if we try to apply this to the Spanish culture or the black culture or whatever, it's not going to be as effective. And right, although it's being applied that way because there's nothing else. Studies show great disagreement. Particularly one of the areas of great disagreement in the hospital took 89 people that had been labeled as schizophrenics. And they had them reassessed. And after they did the reassessment, they ended up with 15 schizophrenics and between 15 and 50 mood disorders. So mood disorders and schizophrenia, for example, have a lot of the same characteristics, and they can overlap, and sometimes we even have some one category in which they overlap. So again, the picture? Now let's go relate this to the Bible. Okay? And we're going to go back to the different tribes of the land of Canaan, and I'm going to relate and tell you where they will fit or don't even fit in the DSM-4. What we find when we study that is that those tribes are a particular way of looking at different disorders, but we're looking at it more from God's point of view. Okay? The first one is what we call the Amorites, which are problems with prominence and significance. Now to God, that's a problem. Do you understand? When a person has pride, when a person is trying to make themselves their own God, when they think they're great and wonderful, God sees that as a problem. Does DSM-4 see that as a problem? Absolutely not. You won't find anything in DSM-4, with the exception that there might be a few personality disorders that have some of those pieces within them. Okay, like narcissistic personality disorder. Okay, where the person's totally focused on themselves, might have some pieces of prominence within that particular area. When we talk about those, we'll get in there deeper. Histrionic personality disorder is another one, where the person is really, look at me, I'm so wonderful, aren't I beautiful? And where they're really flighty and that kind of thing. And that could possibly relate here. The Hittites. That's fear. Now that's fairly well represented in DSM-4. We have the phobias, the anxiety disorder, panic attack, shyness, withdrawal. Codependent, we would call it codependent avoidance in some of these cases. There is a avoidant personality disorder. There is a panic disorder, adjustment disorder, and those kind of things. So we will find a category that sort of fits with fear. The parasites, those are boundary problems. This is the classical dysfunctional family type of thing. And there we have dependence personality disorder is one that fits. Now realize this would be deeper than codependence. In other words, you have a bad codependent, but now you're going something even deeper in this. They're going into unreality. This totally consumes their life. The Canaanites, or low land, or low self-image. Well, that one we're not going to find very much. It's the basis of a lot of things. It would probably be under what they call problems related to abuse or neglect, which really aren't covered in detail on any of the axes in DSM-4. So we don't see a lot of those kind of things. See, that's one of the problems is when we're talking about like sexual abuse and we're talking about physical abuse and so on that we see a lot in counseling, those don't compute out to a particular personality disorder. But God sees that as a major, major problem. The highlights, we said those were life-giving desires or lusts of the flesh. That would be romance, relationship. They don't cover those in DSM-4. Sexual addiction to a certain degree, but not in that level. Eating addictions that are in DSM-4. Said homosexuality is not in DSM-4. So do you see what I'm saying the problem we got? Since we're looking at so medically, there are an awful lot of stuff you see in counseling that it's going to be very hard to fit into and find some category to make this thing all fit. And that's what it comes down to. To get that insurance, you're going to have to make it fit into this particular way of looking at things. The Jebusites, to tread down or to trample down. Again, that's in the appendix. That's not really a major thing. The closest thing that we might get is what's called intermittent explosive disorder. That's the only thing we have in the area of anger in DSM-4. So do you see our problem? When we try to relate this one to this over here, we're not getting a very good match. The thing doesn't come together very well. And the kind of things you're going to see in the Christian counseling realm and the kind of things that the Bible talks about and so on, we're not going to match very well with what we're talking about here in DSM-4. And then we have what we call the Gergesites, which are emotional problems. We'll see those under mood disorders primarily. Also bereavement, which again, see, bereavement isn't even considered a mental disorder. Why? Because it's temporary and because a person normally acts that way. So it doesn't fit into these particular categories that we're talking about. In closing, though, let's look at one model that I want you to think about from a standpoint of mental disorders. And that's what I would call the stress model. The idea is this. As long as I can cope with life reasonably and get my needs met, I am healthy. When I get to the place that I can no longer cope with life and I go into my safety need, in other words, all I want to be is safe, I don't care about my relationships, if I hide in my house and eat and I survive, that's good enough. That's what has been called neurosis. Okay, all I'm trying to do is be safe, and I'm using all these defense mechanisms to make myself safe. Okay? If that doesn't work, I'm still stressed out, I can't even be safe, then I move into unreality. That's called psychosis. Okay? Unreality is saying that I'm somehow going to fix myself by creating something that isn't true. As an example, I feel very bad about myself, and I'm really down, and I'm not very worthwhile. But you know what? If I was Jesus, then I would be a very worthwhile person, right? And that's why in mental wards you find people that think they're Jesus. You find people that think they're Napoleon. You find people that have all sorts of ideas that obviously everybody else knows are not correct. I give you an example. I had a person come in as a client. And this particular client had been arrested for breaking into a building, and they had caught him about ready to rappel off the building. You know, the police asked him what he was doing. He said he was on a mission for the intergalactic forces. So instead of taking him to the jail, they took him to the hospital. But what was the problem? The problem was he was going to the university, and his father had this tremendous desire that he graduate, and he had been drinking and everything else, and he had reached the conclusion that he would never graduate, therefore he was an absolute loser, and he couldn't face his father. So do you understand? If he had been recruited to the intergalactic forces, he'd be worth quite a bit, right? And he wouldn't have to care about college, would he? And his dad would really approve of it, wouldn't he? situation. What is the mental disorder that you would diagnose for that particular person? As we get more into the different types, we'll figure it out. So now let's toss in the last thing. Spirits. How does the spiritual fit into this whole realm that we're talking about here? Well, in America, it doesn't. Because we have what's called dualism, which means we say it's either a psychological or medical problem, or it's a spiritual problem. But what's the real truth? The psychological opens up to the spiritual, and there's factors of both in every one of these issues. I want to give you something to think about. If the person using this stress model is so stressed out that they've given up of life, and that's when they move into psychosis, and they're no longer in charge of their life, they're no longer protecting what they think, is it possible that the thoughts they have that tell them to kill their grandmother, or the hallucinations that they have, or the delusions that they have, are actually spiritual influences in their brain that are affecting them? And that so we're seeing that the more we go deeper and deeper into mental disorder, the more the influence of the spiritual realm in there and the possibility of spiritual control comes into this particular thing. See, the question is, if you're in a rage and you're no longer in control, then who is? You see the overall picture I'm painting? Okay? That basically we have different ways of looking at things. In this course, we're going to try and take this secular way of looking at things called mental disorders and diagnosis, and we're going to try to integrate that with the spiritual way of looking at things, also with the recovery way of looking at things, and try and tie all this stuff together and try to see how much sense it actually makes. Let's pray. Lord, we realize that we're embarking in a situation here where we don't have all the answers. And we ask that you would open our minds and our hearts, that you would teach us throughout this course, that you would put it together, that it would be valid and according to your word, Lord, because we trust your word as being the absolute rule in every situation. And we ask, Lord, that you would give us the wisdom necessary to do this. In Jesus' name.